Welcome back. Now we move on to the panel keynotes and discussions. To chair this session, I would like to invite Professor Raghu Raghavan, Professor of Mental Health and Director of Mary Seacole Research Centre, De Montfort University, Leicester, UK. He is the Principal Investigator of MeHeLP India. Welcome, sir.
Good afternoon and good evening to everybody. So I hope you've actually enjoyed the previous sessions and the workshop. I see a lot of participants in the workshop. So thank you for coming to the last session of today's conference. And we are in the midst of a galaxy of stars for this session, and I'm very privileged to chair this session. And I think it's going to be an exciting discussion on mental health literacy, and I promise you that. So feel free to put your questions through the Q&A tab and also raise your other comments to the chat box as well. And do feel free to actually get into our lobby from time to time. I mean, tomorrow or whenever you are actually going to be, or Wednesday, there's a display of a number of artifacts and documents and details in our lobby. So great to welcome you all to the final session of the Pan-India Mental Health Literacy Dissemination Conference. We have 5 excellent speakers here, and they're actually going to deliver their talk one after the other. And I'll introduce all of them together, and they will come on stage, and then they will go through their discussions and their talk in the right order, I hope. So, first of all, we have Vijay Nallawala. Vijay Nallawala is an author of the book A Bipolar Journey, a friend as well. I have had a lot of conversations with Vijay over the last few months, and we have bonded well in relation to what we want to say together. And I think good to have you here, Vijay. And he has actually written the book, A Bipolar Journey from Torment to Fulfillment, published globally in 2015. And his story was also featured in the book, Heroes Amongst Us. He is a founder of Bipolar India, a pan-India peer support community for persons with mental illness and their families, which was founded in 2013. He is an entrepreneur of 30 years. For 30 years, he has lived experience of overcoming bipolar disorder. He firmly believes in a holistic approach to healing, and that recovery needs to encompass all important aspects of a person's life. With his team at Bipolar India, he is currently working on an initiative focused on livelihoods for persons living with mental illness. It's a pleasure to welcome you, Vijay Nallawala, to our final session of the conference. Next, we have Priti Sridhar. Priti Sridhar is CEO of the Mariwala Health Initiative, a grant-making and advocacy organization on mental health in India. Priti leads the Mental Health Initiative, rights-based work, and oversees the project management, grant management, and advocacy initiatives. She has almost 25 years of work experience in both for-profit and not-for-profit organizations. Priti has worked extensively in finance, strategy, and HR, and is passionate about women's rights, mental health, and child rights. She aims to combine these experiences with her interests in rights-based mental health work to spotlight and support organizations and leaders focused on community-based organizations. What an important theme that we need to have today and tomorrow and the days to come in terms of improving the mental health literacy of India. So very welcome to you, Ms. Sridhar, to our conference, and very warm welcome to you to this program. Next, we have Dr. Rajeev Das Gupta. He's graduated in medicine from the University of Kolkata in 1989 and obtained his master's and PhD in community health from JNU in New Delhi. He served a decade with the epidemiology division of the Municipal Corporation of Delhi and joined JNU in 2003, where he is currently professor and chairperson of the Center for Social Medicine and Community Health. He was a Fulbright Senior Research Fellow and Visiting Associate Professor of Johns Hopkins Bloomberg School of Public Health during 2010-11 and a Visiting Professor at the University of Technology of Sydney in 2016. He is closely engaged with the Indian Council of Medical Research, ICMR, and the National Certification Committee of Polio Eradication, and the National Health Mission, as well as several other key national health programs. He has been a consultant to UNICEF, World Bank, and Save the Children. He is widely published in national and international journals. He is a managing editor of the Indian Journal of Community Medicine during 2012 to 2014, and currently the managing editor of the Indian Journal of Public Health. He's a regular commentator on public health matters and national and international electronic and print media. Very warm welcome to you, Dr. Rajiv, to our final session for this conference. Next, we have Dr. Rama Kumar. Dr. Rama Kumar is a clinical psychologist with over 30 years of experience. She is a senior consultant at the Institute of Child Health at Sir Ganga Ram Hospital in New Delhi. And since 1991, and at the Max Super Speciality Ganga Hospital in Gurgaon since April 2012. She has been recognized by the various communities and associations for her influence and growth in the field of psychology in India. She works with organizations, teams, families, couples, and individuals to foster improved communication and solution-based strategies and allow positive outcomes for many. She has devoted much of her career to helping people find the necessary mental health resources for their needs. She empowers her clients to evaluate their current situation, sees new ways of approaching change, and identify practical solutions and uncover tools that help them to positively approach change. A great theme for our conference on mental health literacy. Very warm welcome to you, Dr. Rama Kumar. And last but not least, we have Shubhrata Prakash. Shubhrata Prakash is an officer with the Indian Revenue Service, and at present she is posted as Director to the Government of India at the Niti Aayog, New Delhi. She holds a Bachelor of Science degree in Mathematics and from St. Stephen's College in New Delhi, an MBA from Xavier Institute of Management in Bhubaneswar. She has briefly worked in the field of advertising before joining the civil services.
I think it's the virtual mode. I think we are not able to locate Raghu. He'll join back, but in the meanwhile, request Vijay to take on the presentation. You are able to screen share?
Yeah, I'll be able to.
Yeah.
Just a second. Is it visible?
It is visible. Yes, it is visible, Vijay.
Yeah. Thank you very much to the panelists, my co-panelists, to the chair, Dr. Raghavan, to MeHeLP for organizing this wonderful conference and getting us together here. We all know about what the deficits of the Indian system are in context of the mental health situation, and I think these are prevalent globally, but could be accentuated in a country, a developing nation like India. Lack of awareness, the overwhelming stigma and discrimination against people with mental health conditions, the isolation that people feel, and the care gap which we are all again all aware of. So I'm using the peer support model of Bipolar India to showcase how peer support models can sort of serve their purpose and fill these deficits to a certain extent. Let's address lack of awareness. We all know about the gap in treatment, where the statistics say that 80 to 90% of people living with mental illness do not access mental health care for various reasons. It could be being unaware about that there would be specialists available to help them because of various conditioned mindsets which guide families in rural India towards spiritual healing without first exploring the formal approaches of treatment. Uh, so how does a peer support model help in? Here, I will also like to pinpoint on one aspect about the, we when we talk about the care gap, we also know the limitation that the psychiatrists and the other practitioners in India face vis-a-vis the demand and supply gap. Right? So, a psychiatrist in a public hospital might be seeing hundreds of patients in a day, and in that given context, the time frame to address a single patient would be hardly 5 to 10 minutes. So the lack of communication does not really do justice to the communication needs of the person. So peer support community helps fill the gap to a certain extent by helping the person understand what the condition is about. I mean, depending on the diagnosis. So we do the sort of soft sort of educational kind of an approach to that person, and fill in about the symptoms of the condition, the coping mechanisms, what are the red flags to watch out for, and in the larger context, how to overcome that condition. All right. We work in an offline as well as an online model, and this ensures that our reach extends to the remotest parts of the regions of India. Yeah. So places in in villages in Bihar to Kerala to Assam, we have had people connecting with us through our various virtual platforms, as well as our online meetings, plus of course our offline presence in the various metro cities in India. Very often we have noticed that there is an overwhelming sort of a focus on the biomedical model of healing, which is rarely suited to chronic mental health conditions, especially severe conditions such as bipolar disorder, schizophrenia, even severe depressive cases. Uh, so our approach is to guide people to adopt a holistic approach in healing, which would encompass exercise, sleep, hygiene routine, yoga, pranayam, nutritious diet, and so on and so forth. We have used the vehicle of various conferences and events to disseminate information, create awareness, build conversations. So our first World Bipolar Day convention was held in Mumbai at the SP Jain Auditorium, Bombay Hospital in 2016, and that has been an annual feature, except of course during the COVID pandemic when we have gone online with our events. Right? In addition to that, we also conduct peer support meets. Our peer support meets began in Mumbai in 2016, uh, where we began with that offline model initially, and the meetings were held in Mumbai once a month on a Sunday, which was convenient to most of the community. Since 1.5 years, we have shifted to the online mode, and we have conducted over 30 meets on various topics, in addition to the general meets, which are just an open forum for people to, share their concerns. Do we just talk about the health aspect of recovery, about the symptoms, about the medication, approaches available, about psychotherapy, or do we go beyond that? When we talk about lack of awareness, just does not limit itself to the lack of awareness regarding mental illness or mental health. It also extends to lack of general lack of awareness of a person's rights under the various acts and laws under the which are already in place. And therefore we also try to educate people about their existing rights, especially in situations where we feel they are shortchanged due to their lack of knowledge about such rights. Yeah. And for instance, we have also actively involved ourselves in advocacy for procuring health insurance for persons living with mental illness. So already, although the act is already in place, the IRDS issued its guidelines, but we see that on ground, this is still not happening at an adequate level. We educate the person about uh, his or her rights in choice of treatment, uh, denial to be hospitalized against his or her wish if the condition does not justify that, and so on and so forth. So this is one instance where we had conducted this workshop on the Mental Health Care Act, so that people would get a ringside view about the rights-based approach, which the Mental Health Care Act 2017, we all know, has been a game changer in terms of empowerment of the persons with mental illness. And we felt that building awareness about our the various facets of the act and how it empowers us is a it's a knowledge which is worth imparting. Among the other problems that we noticed that around people living with chronic and severe mental illnesses is the isolation that it causes. I remember that when I was initially diagnosed and when I was in hospital, the overpowering thought that came to my mind was that now I am diagnosed with a severe mental illness and I am mentally ill. And the thought which was the most overpowering to me at that juncture was the fear of being absolutely alone, feeling that I was the only person living with this condition. So it is a very isolating sort of a feeling. Yeah, I wish I had this kind of a peer support community to support me back then when I was diagnosed and going through a lot of torment. Communities help people connect to people with similar struggles, help them realize that they are not the only ones going through them, help develop resilience, help, and we all know how therapeutic opening up is, just opening up, and speaking to somebody who is not going to be judgmental, who is going to listen patiently, and and especially that the person understands what you're talking about, the person has actually been through what you are also experienced to some extent. So the conversations happen in a very safe space, and in fact we have noticed that sometimes people say, I find that the community understands me better than my own family members. That is how stark the contrast is. Because of lack of awareness, we know about sometimes the issues being gaslighted by even dear members of family, because they do not have a proper grasp about the situation. In general, this leads to development of trust and, in a long run, bonding between members.
Vijay, I have to caution you. Maybe we are running beyond the minutes that
Oh,
has
sure.
been given.
Sure. Our community is connected 24 by 7 on apps, on various apps. It works like a crisis helpline. And the coping tips which are shared are on lived experience. That is why they are more sort of believable to the persons receiving them. Focus shifts from symptom management to recovery then. We know all about stigma and discrimination, but we believe that we can endlessly go on about stigma, but we need to tackle more about the issue about how stigma works in real life. And that's why we believe discrimination is stigma in practice. And this is where we have recently launched this initiative for livelihoods. It's named as Let's Walk Together. It's an initiative which will be a bridge between organizations which will be willing to employ people with mental illness, and we being the people who will showcase their profiles and careers on this domain. And we have been supported by Center for Mental Health Law and Policy, Manorati, and Mariwala Health on this initiative, and we are extremely thankful to them. Overall, how do peer support models work? It is the bias and for us democratic concept which helps create that sense of trust and belonging. Lack of hierarchy, moving from isolation to community, and it in general that people feel that being in the community will help improve their quality of lives. Yeah. I would like to end by saying that we should be thankful to a panel of experts that who have selflessly contributed to Bipolar India and helped it build to this level. Dr. Milan Balkrishnan, Havavi Bhagwagar and Zina Jahan, who are psychologists, our yoga expert Shrikant Shirsagar, and nutritionist Shilpa Mittal. Yeah, thank you.
Raghu, we are not able to hear you. We are not able to hear you.
Okay, thank you. It's the joys of actually sitting in a different country and trying to organize something in a different country. So I think it's so. Thank you very much, Vijay, for the excellent conversations in relation to
Thank
your
you.
own experiences and how building something new in relation to bringing people together through peer support models. Um, Many thanks for your conversation. We come back to the questions at the end of the session. We now go to Priti Sridhar. She's going to talk about inclusive rights-based approaches for promoting mental health literacy. Over to you, madam.
Thanks, Dr. Raghu. I wanted to start my talk on inclusive and rights-based approaches for promoting mental health literacy by saying that lack of knowledge on mental health is said to drive prejudice that then leads to discrimination against mental health issues. Promotion of, therefore, mental health literacy can be useful across three dimensions. One, increase in help seeking behavior. Two, healthy attitudes. And three, the absence of stigma. Mental health literacy, however, needs to move beyond stigma reduction and lobby for adequate, accessible, and quality mental health services. It shouldn't be framed around personal responsibility of the individual with mental health issues, but also address underlying factors such as structural violence and unique stressors causing psychosocial distress. Therefore, inclusive and rights based methods of promoting mental health literacy must be related to accessibility. What will therefore make an accessible service or awareness program? One, that it includes the how part, which means they need to account for different languages. For instance, in India, different categories of population may speak different dialects despite being geographically close. Mental health awareness therefore needs to account for this. For example, one of the potential partners that we were recently talking to was based in Nagaland, and he mentioned that there are 11 major tribes there. So, their mental health awareness needed to account for each of these tribes and their language. Accessibility also means the mode of communication used. While apps, technology are considered newsworthy, it is important to consider digital divides in India. Mobile phone ownership, internet bandwidths, and speed while adopting them as a medium to disseminate mental health awareness. Smartphone apps, therefore, need not always mean accessibility. One example of a smart use of One example of a successful use of a smartphone to have accessible mental health awareness conversation is being implemented by MHI partner Center for Mental Health Law and Policy in their Atmiyata program. The program recruits and trains two tiers of community volunteers called champions and mitras to identify and provide primary support and counseling to persons with mental health issues. A feature of this program is the use of simple technology. Champions are provided with smartphones, which have short films meant to build community awareness around issues related to distress everyday situations like domestic violence, alcoholism, unemployment, relationship issues, etc. Now, the uniqueness is that the films can be shared via Bluetooth without the use of internet, encouraging wider discussion and helping to depathologize the subject of mental health. Atmiyata, in that sense, is unique for its focus on psychosocial stressors and common causes of distress in its training, service delivery, and the language it adopts. Accessibility can also be measured in terms of where is this service delivery or awareness campaign being held. For instance, does it take place in physical spaces such as town centers and town halls, which may reinforce structural inequalities, as several of these spaces tend to be available to dominant groups and out of bound to people because of caste, class, ability, or are these being held in informal or temporary settings? Again, another example I would like to use is of the Seher program run by another partner of MHI, Bapu Trust. Bapu initiates conversations on mental well being in resource poor communities in street corners and neighborhood spots in Pune, thus making it accessible and ingrained within the urban busty culture of Pune. The fourth aspect of accessibility is factoring in cultural context. Again, another partner of MHI, Anubhuti, initiates conversations on mental health with women in their community by linking the moods to salt in cooking and saying that sometimes it goes up and sometimes it goes down. It then encourages women to seek support in the community center when they feel that the salt is not right and not use technical jargons like mental health awareness or like common mental health disorders to initiate these conversations. In fact, many of our partners, and we currently have 27 of them, with most of them being community based partners, therefore use words like tanav, tras, or stress to communicate mental health issue. Another potential partner I recently visited uses storytelling to initiate the conversation on mental health. The last aspect of accessible mental health awareness building is that ethically it should also include components of service delivery. At the very least, community members who are initiating this conversation on mental health should be trained to make referrals to mental health professionals. It is also important that mental health literacy is inclusive of people with lived experiences of mental health. It is important to facilitate the participation of experts by experience, as Vijay mentioned, in the delivery of information and literacy. While there is a strong temptation to take an expert led, top down approach in mental health literacy, we must guard against it. Amongst other factors, these approaches tend to be expensive and unsustainable, Again, something that Vijay pointed out by saying that psychiatrists are very limited in India. Um, for example, to make it sustainable, one of our partners, Burhans, uses a tool that has been designed by the community to initiate conversation on how do we know if a person around us is mentally okay. The community has decided what mental health means and what recovery would look like for them. It is important to acknowledge um, the contribution of community based approaches to mental health as they foster a high sense of ownership and drive among the community to promote mental health education and literacy. A community based approach foregrounds the community and underlines that people are experts in their own context. It is also important from a rights point of view that these programs integrate with existing public health facilities and services. The focus should be to build capacity amongst existing government resources to be more inclusive and accessible and leverage them rather than creating expensive parallel private systems. As we talk about rights based and inclusive mental health, it is also important to look at what causes mental health distress. Do we see it as a developmental issue or a medical issue alone? For example, a lot of conversations today happen on school mental health. In promoting inclusivity and rights based approaches for mental health literacy, we also ought to examine assumptions about teaching self awareness and self regulation in school settings, as is done through programs like socio emotional learning. We must consider whether, in the face of an unequal world and systemic operation related stressors, if this kind of teaching is enough to support mental health, or it may actually reproduce harmful messaging that has to simply become competent enough to do well. For a child who is facing distress due to systemic violence in their lives, before and after school, what does being taught self awareness actually accomplish? Does it lead to a better understanding and ability to support their mental health, or further cements that their feelings are not okay? It the current Most of the current program also assume that a child should have certain behavior within the school irrespective of the challenges that the child may experience outside the school, say about domestic violence, financial distress within the family, caregiving responsibilities of siblings, etc. Such programs rarely acknowledge these realities that have a huge part to play in children's emotions, behaviors, and mental health. And these challenges may not be easy to overcome for the child. It is also therefore important to understand that not all community based programs are rights based and inclusive. Also, for school based mental health programs, if we take the conversation ahead, to be truly inclusive, it needs to acknowledge how a child from a Dalit background or a child who has disability or who comes from a single parent home experience the teaching under the resilience building programs that have been borrowed by many concepts from the West. And even there, they have not been relevant for many children from other marginalized backgrounds. To end, I would say that rights based approaches to mental health literacy that are also inclusive would mean that one, they're delivered by people from the community who are acknowledged as experts and not just as part of task shifting. Two, the design is based on the understanding that multiple factors impact well-being. Three, that there is a component of service delivery for persons who experience mental health issues and there is a strong referral system. And lastly, rights based work needs to aim to integrate the work with the public health system. We cannot be aiming to create a parallel economy where the NGO sector is delivering services on behalf of the government. Over to you, Raghu.
Many thanks, Priti, for that excellent talk, identifying the examples of practice, the inclusive practices that is actually around in Maharashtra, and also focusing on children and how we should be looking at a whole family model, perhaps, and various and the diverse models that should actually exist within the country, because obviously there is no one standard measurement or standard way of actually doing any of those things. And I think that diversity brings the richness and also broader understanding in both urban and rural India. Many thanks. There are loads of points that I think that people might actually want to come on from your conversation. Thank you very much indeed. So I now go to Dr. Rajeev Das Gupta. He's going to talk about bringing systems thinking into India's national mental health program. Over to you, Dr. Rajeev.
Hello, and
Hello.
good evening, and thank you. I'll put this on full screen. Is the slide visible?
Yes, it's fine.
Okay, thanks. Thank you. First, many thanks to MeHeLP and Professor Raghavan for this invitation, though I'm not really a mental health, I don't really work with mental health. But because I work with health systems and health programs, I thought of this topic. And this is not to provide any answers to some of the very complex problems that the National Mental Health Program faces, or even to be prescriptive, but this is just to bring into conversation systems thinking and how and why systems thinking is relevant to any health program, and in our case, or in this case, the National Mental Health Program. I hope the slide is moving.
Yes, fine.
Okay.
Yeah.
Okay. Thanks. So this is to highlight the National Mental Health Policy 2014, which is an extremely rich document, as all of you working with various facets of the National Mental Health Program are certainly aware. What I put in this slide are several values, objectives, cutting issues, and strategic directions that the document talks of in connection with programmatic or health systems issues. There are a lot of values, objectives, strategic directions, and so on that it talks of, but this is just to flag some of these issues. Now, all of these are important as far as systems thinking goes, but I'll not get into individual elements, but really give you a broad overview of why systems thinking is relevant. Following this, the central government or the federal government issued a set of guidelines which the states follow, and fund allocation is based under these heads in line with the central guidelines. So these are in terms of human resources, in terms of upgrading institutions, in terms of administrative teams, plus training and research, IEC, and monitoring and evaluation. These are the heads under which the NMHP allocates funds to districts, to the state level, and then down to the district health societies. And when we come to the district mental health program, it looks something like this. It's a schematic diagram from the Mental Health Observatory. Now, essentially, what this tells us is that this is an extremely complex program, like all national health programs are. It's got multiple elements, and each of these elements are building blocks of this program. And therefore, the challenge and the question is, how do we really translate from each of these building blocks to the mental health, to a meaningful mental health program as a whole, whether it's at the district level or the state level or at the national level? Now, many of us in this panel or in this conference are actually domain specialists whose inputs are very significant and valuable to these individual components and building blocks. And therefore, as the theory and jargon goes, that's where design thinking comes in. Uh, to take any element among this, such as a school mental health program or a community-based program, or even say suicide prevention and so on. Each of these requires domain specialists, such as many of you here. But challenges in national health programs are really complex entities where simple blueprint approaches have limited success, and the blueprint approaches are really for these building blocks. And developing each of these building blocks individually is in the realm of what's known as design thinking. Now, I'm not getting into design thinking today, but that's what essentially design thinking is. Now, you will realize and will link that each of these belong to one of these 6 health system building blocks under the WHO health system framework. And this is how funds are allocated. This is how um, operational decisions are made, whether at the district level or at the state level. But in the same vein, as the WHO understanding goes, and there's a WHO document which dates back to 2009, which is the same time as the final report of the Commission of Social Determinants of Health is published. So this belongs to that era within the WHO. That each of these elements are intersecting. uh, all of them have people at the center, and therefore it's this complexity that comprises of what the health system would be. The WHO therefore defines systems thinking as an approach to problem solving that views problems as part of a wider dynamic system. And therefore, systems thinking in the health sector is about the nature of relationships among these building blocks, the spaces between these blocks, and understanding what's happening there, and the synergies emerging from interactions among these blocks. And this essentially is what health systems thinking is. But it needs a deeper discussion on trying to make sense of systems thinking. Essentially, a system is a relationship of parts that work together in an organized manner to accomplish a common purpose. And the common purpose here is the mental health program at the respective level. But one needs to make a deeper sense of what systems thinking is and how does one move forward. So a system means different things in different contexts. It could be, the question is that, is it only a material assembly of things, of people? Is it an organic group? Is it harmonious? Is it orderly? Its parts can be objects, people, actions, products, ideas, beliefs, so on and so forth. Sorry. And the emphasis is really on being able to work together, what the mutual influences are, what the reciprocal actions are. And there are certain emergent properties of a system as it goes along, as the mental health program moves on. It's still, as a program, it's still at a relatively nascent stage compared to many other national health programs in India. And these emergent properties that we identify belong to the system rather than the individual properties of the parts. Now, many of the domain experts work deeply with these parts and not necessarily with the systems, though each of these parts certainly contribute to the system. Also, is the system resilient in the face of an internal and external disturbance? For example, the immunization program in India currently, it's faced COVID. which all programs have faced, whether it's TB, whether it's HIV, whether it's national mental health, it's a mental health program. But different programs have shown different degrees of resilience in face of the COVID challenges, and the degree of the resilience that each of these programs have shown is essentially a function of the strength or weakness of the program as a system, and therefore the health program or the health system as a system, is it adaptive, and has it got the ability to evolve? There's also the question that why the system exists. Now, the mental health program, for example, it's coming up or being built on a foundation of many institutions, of many governmental and non-governmental activities. It has a whole clinical care system, a community care system, and so on and so forth. So the system exists. It's not that a new system is being created, and therefore the questions that we need to ask ourselves are: what purpose does the activity of the system serve or achieve? What is the function, goal, value, or principle that unite the system as a whole? Indeed, whether the system is at all united as a whole. Is the intent adequate for the long-term sustainability of the system? And that becomes very crucial for programs that, and particularly programs for chronic conditions that really go on for decades. And therefore, what are the criteria for a successful system or system intervention? The application of systems thinking in the health sector is currently accelerating a more realistic understanding of what works, for whom, and under what circumstances that all of us engage with, including in this program. And this essentially is a terrain of philosophical, ethical, and political controversy, particularly a program so sensitive as the mental health program. System thinking is increasingly coming into public health programs, whether at the national level or for global health programs. And theories and methods are both important. These involve multiple interacting agents. It's the understanding of the context is relevant because the context in which these elements operate keeps changing, whether it's a new drug or whether it's a new communication technique or whether it's a new policy shift, new funding protocol, and so on. And the challenge in systems thinking is the manner in which things change do not conform to linear or simple patterns. The systems thinking comes with a set of tools, which we'll see. And the public health programs, therefore, are concerned with both theory and practice, and therefore there are various models. And models tend to replicate the complex conditions in which we work. But then, as one of the scholars put it, that all models are wrong, but some are useful, and therefore we keep looking for these useful models. And systems thinking naturally comes with a diversity of models. This is from the WHO 2009 document. These are the various skills of systems thinking in contrast to the usual approach. So the systems thinking is characterized as a dynamic thinking instead of a more static thinking. It's an operational thinking. It's a loop thinking. So there are causal loop models. There are various tools of systems thinking and various skills. So there's systems organization, there's systems network, systems dynamics, and systems knowledge. Now, as I said, I don't. This is not intended as a prescriptive talk, but really as a sensitizing talk, or just putting these issues on the table as to how we can bring systems thinking into a very complex program as the National Mental Health Program. So health interventions may be aimed at individuals, which may be new drugs, vaccines, or diagnostics, generically speaking, and the mental health program or clinical care for mental conditions has seen immense development in drugs, for example. These interventions may also be at the population levels, such as legislative efforts, such as health education systems, education elements. But all of these interventions are actually carried out through what's known as design thinking. However, putting all these together is relevant and important because these interventions may be unexpected or unpredictable with implications for health systems, for the typos, that are more complicated than first appreciated. And systems thinking, therefore, adds to the theories and methods and tools that we otherwise use in public health. It's another layer of methods and tools. Really, it's not that it's very significantly different from what we do, but the the core point that needs to be understood is that each of these or engaging with each of these or improving each of these is really design thinking, what's understood as design thinking, and how we knit this together uh, to a meaningful program that's where systems thinking comes in, and the methods and tools of system thinking comes in. I'll end here and thank you again for this opportunity, and happy to discuss further. Thank you.
Thank you, Dr. Rajib. That was an enlightening way of actually looking at how it all falls within the systems thinking process. And I think the diversity and how we can actually bring the various factors, elements, and people and their conversations and engagement into that process as well. Many thanks. We'll come back to you in the kind of question. I think we'll carry on with the session. Thank you very much indeed. Our next speaker is Dr. Rama Kumar, and she's going to talk about mental health literacy for thriving with resilience in the face of adversity, a topic that is very dear to me too.
Thank you so much, Dr. Raghu. Thank you so much, and thank you, MeHeLP, for giving me this opportunity. And just like to start. So we are aware that resilience has been a very big part of the current system that we've been going through from March 2020 about the adversities that all of us have been seeing. So I think this is a very relevant point and a relevant topic to understand that how we all need to bounce back, especially when there's a adverse situation and we have no idea how to get back. So let's understand that it's the courage to come back. More important than anything else, it's the courage to come back, and we have to have some skills and tools, and we learn this while in our growing years, while we are being parented. It begins right from childhood, and that's what we need to understand. Emotional resiliency is the ability to bounce back emotionally after experiencing distress. We've all experienced a lot of distress in the past over a year and a half, and almost going to be 2 years now, especially the younger children who have been away from the social interactions, and most of us have been working from home. So there's been a lot of emotional upheaval that children and young adults have gone through, and also the other population has gone through, and how it's important to be emotionally resilient to be able to bounce back in the case of an adverse situation. So when there's an adversity, which is a challenging situation, it's the belief that gets us going. How do we interpret the situation? What are the consequences that go through that? What you do or feel as a result of the situation? It's the ABC model of resilience works the best, and of course, it's based on the Albert Ellis work that psychologists are aware of. We've all had calamities and the human spirit, and I would say that in India, while I was growing up in 1971, where the war was there, my parents come from the defense background, and how we stayed in one of those sectors which is very close to the border, and how we were made to get into trenches and how we lived those days, I think I still have that memory, and how that has actually got us very, very resilient, and we've learned how to deal with adverse situations and calamities. And most of us have seen a lot of calamities in our lives, and the calamity is not just the natural disasters, but certain disasters or certain traumatic situations that take place while in our growing years, especially if there's a broken family, if a relationship is not going good, if the child who's been in one section of a class and that section has been distributed to, I mean, the children have gone into various sections, and this child then starts feeling completely isolated because his or her friend has gone away, that is also a traumatic situation. How we interpret is most important to understand. What is this skill and why do we need it? It teaches us to bounce back. Can you think of some people who bounced back? The Japanese after the World War II, the Germans after the World War II, India after 1947. We have so many stories. My own parents who came from Pakistan during that time have so many stories. My grandparents gave me so many stories, and those are real life experiences. I remember my grandmother telling me the story that I had to come from Karachi, and she actually tied around all her jewelry on her body and wore her clothes. And that's how she was able to help her husband, my grandfather, to build up a business, and they had 4 children. So how do we take that forward? People like J.K. Rowling, Amitabh Bachchan, people with handicaps who have climbed mountains. So what is this skill, and why do we all need it? What is it that stops us from getting this skill? How did they get it? How did they do it? They managed adversity. They adapted and innovated and built some blocks for themselves, and that's how they bounced back. What are the characteristics of resilient people? They're able to detect the cause of their problems. If there is a problem, what is it that is triggering? Is it really repetitive, or is it only one area that needs to be fixed? They know how to handle their emotions. And I would say, well, coming from India, that most of us over here are not given an opportunity or are not even raised in a manner that I can express my emotions. If I express my emotions, if I say I'm sad, I'm told, why are you sad? You shouldn't be sad. There's no reason for you to be sad. But I can be sad, So I have to be able to express my emotions. A person who has developed a fair enough amount of resilience keeps calm in stressful situations. They're realistic, they trust themselves, they have a lot of faith on their own self, and they are empathetic. So these are the main characteristics of people who carry with them a lot of resilience. How do we do this? We need to reset ourselves, reset our goals, reset our priorities, and reset our expectations from ourselves. The problem happens when all of this gets wobbly in a sense, or you are in mesh situations, so you are not able to reset your goal, reset your priority. You don't understand what is your priority. You don't keep a plan A, plan B, plan C. It's all muddled somewhere. So we have to learn to reset ourselves and rebalance our work, our family, ourself, and in the society. How do we rebalance? So COVID has actually taught us a lot of these situations where we started working from home. And look at us, this conference, where in earlier times we would probably travel so many places to go through this kind of a conference, this kind of a very well done up conference. So we've learned so many things, we've adapted, we've learned newer techniques, and this time also taught us a lot about the screen, about the artificial intelligence. So we learned so many things, so we need to rebalance ourselves. We also know that everybody's been talking about keeping our healthy routines, but do we really understand what these routines are? We do need to exercise regularly, especially walking, but keep within 2 kilometers of your home. Don't go very far away, because People who've had COVID are going through still those post COVID situations. Our children who've loved to play in the parks, in the communities where they are having community living, they've been unable to do it. Keep regular sleep routines. Our sleep hygiene is majorly affected, and especially if we know that one third of our lives is where we are in the sleeping mode, and that's the most important area. So most of the pathology that ever comes up is from our uh, difficult or problems during the sleep time. Maintaining a healthy balanced diet, a lot of us have gained weight, a lot of us have lost a lot of weight because of being at home, because of being in vulnerable situations back at home, being in tough situations. We've not been used to staying together for so many hours, days, weeks, months together. Avoiding excessive substance usage, practicing relaxation techniques such as reading, breathing exercises, reading books, searching for. A lot of us have gone into doing a lot of online stuff. But all in all, I think improving our mood by doing something creative, by doing something which gives us pleasure, which gives up that happiness, I think that's what is most important. If I was to just ask you that, take a minute and make a note of one thing that you have done to adapt over the last few weeks, that one thing, you'll probably understand how you've been able to adapt, how you've been able to reset, how you've been able to rebalance and bounce back. And did you ever think that it was possible? We all thought it was not possible, but look at all of us. We've learned so much. And that's what we need to teach our children. Our children need to be given the opportunity to be able to deal with failures, deal with challenges. The number of suicidal ideation that is coming up with younger kids, anxiety and panic attacks in children as small as 4.5 year olds. What are we doing here? We need to raise them, we need to talk to them about sharing and talking about their emotions. So after corona, what the world is looking like, we're all working remotely. There is definitely less travel. We're managing our finances in very different manners. We have more time with the family. We've learned to share housework. We're breathing easy. There are struggles at job, but we are learning how to deal with them. And we are continuing to be careful, but we also have learned how to spend more time with ourselves, most important. We also, you try to anticipate distress and support each other. It is understandable when somebody is vulnerable or somebody is going through a also. A lot of us you know don't understand the meaning of self-care. And self care is actually being with yourself, just being with yourself. For example, I work many long hours, and the current situation is where, of course, I'm dealing with a lot of counseling sessions with, many countries and with different time zones. I do need to take care of ourselves because myself, because I need to take care of my sleep pattern, my eating pattern, and just being me with my family and not just doing the mental health or taking care of everybody else. So it's important to take care of yourself. Be not non-judgmental, empathetic, honest. The normal reactions toward the lockdown, connections between experiences and feelings. Let's acknowledge that each one of us is different, and each one of us has learned to build up newer skills. Safe verbalization of our feelings, and not feel judged and shamed. A lot of us have been feeling attacked by the way or our behaviors. Uh, Resilience, all in all, means managing adversity. We're learning to adapt and innovate, and thus we bounce back. So I'm just going to talk about something known as the growth mindset. Resilience actually means a growth mindset where we are working, where there is we are persevering in the face of failures. There is an effort required to build up a new skill. We're not going to be in a fixed mindset. When there is a growth mindset, I will say failure is an opportunity to grow. That is something that is teaching me. Challenges help me to grow. I like to try new things. Feedback is constructive and it's not always, uh, I'm not feeling shamed all the time when somebody is giving me a negative feedback. Whereas if there's a fixed mindset, what really happens? You start thinking that failure is the limit of my abilities. I'm either good or I'm not good. I don't like to be challenged. I'm fixed. I'm not willing to move away from there. When I'm frustrated, I give up. So we need to move away from that fixed mindset and also think that, are you a victim or are you a winner? You know when you're a victim, you start blaming, you create excuses, there's denial. Whereas when you are coming out as a winner, what really happens is you start taking ownership of situations, you take responsibility, and you also feel accountable. So that's what is resilience and building up resilience. Well, we all know who this person is. He was in isolation for 27 years, no family, no luxuries, no phone, but he had a vision. And we know that we all can do this. Today, more than ever, people need an emotionally safe environment at work and home. So, 9 things that are very important before I end is, let's be realistic. We need to be a little sensitive and look out for if there is anyone who's having any breakdown symptoms. Be supportive. Let's trust each other. Be inclusive, include everybody in the decision making. Be calm, be determined and decisive. Let's all lead by example. And if unsure, let's ask for help and guidance and not feel a stigma towards mental or emotional health. So the key takeaways have been, let's bend, not break, accept reality, adapt and innovate, reset our goals, priorities, expectations, recharge our outlook, approach, skill, our teams, recognize symptoms and act, and promote and provide emotional safety. The essence of resilience is, I can do it. And after rain comes the rainbow, we know it. Thank you so much.
Many, many thanks, Dr. Roma, for that uplifting and highly informative in the talk from you. I think this is resilience is the key to life, and I believe resilience is everything. And I think with mental health and well-being, there is the resilience model that should be built in with mental health and resilience. And I think we trying to, and I think resilience is a buzzword around the world these days. But I think it is important that we try and understand what it is. Many, many thanks. We'll come back to you in relation to the questions, really. Lastly, but the last discussion that we have is with Shubhrata Prakash, and I'm sorry my internet connection went bust halfway through introducing you. Sorry for that. So she is also the author for the D Word, a Survivor's Guide to Depression, Pan Macmillan India publication, and the book of poems titled The Ink on Water. She's a mental health advocate and has spoken at several prestigious forums, including UNICEF, Bangkok, and literary festivals. Over to you, Shubhrata.
At the outset, a big thank you and gratitude, Dr. Raghavan and Mental Health Literacy Project, for having me on this panel discussion here. And while I'm speaking, I'll also just try to share my screen with the presentation. So I hope this is visible.
Screen full share.
Yeah. Is this visible now?
Yeah, that's fine.
Yes.
Thank you.
Okay, thank you. So before I start going over the slides of my presentation, I would just like to go back to a time when, about 10 years back, when I was first diagnosed with major depressive disorder. And as far as mental health literacy is concerned, well, I had absolutely zero literacy. I had no idea either about mental health or mental disorders or depression. And so much so that it's kind of shocking, because I'm an educated person, a fairly well-educated person, and I also come from a middle-class family which has a fair level of education, and no one knew I was a civil servant. I did not have any idea about mental health. In fact, when I was diagnosed, that was 5 years after I had first started showing signs of depression. It started with postpartum depression, and I had a couple of repeated depressive episodes, but it was diagnosed only after 5 years. And the flags were missed by everyone, by the healthcare providers, by my other doctors, by so many doctors in my own family. No one ever even flagged that this could be depression or this could be a mental disorder. So that is the level of mental health literacy that was present in me and my immediate surroundings. And when I was trying desperately to get better, when I had severe depression, and I was looking for ways to help myself get better, what hampered my recovery to a large extent was the stigma. Because I was getting a lot of these stigmatizing messages from society, a lot of unhelpful advice, which was like, get up, you'll be all right, go for a walk, you will be all right, which just didn't help in any way. And the stigma was so much that it was almost like I am not getting better because I am not trying hard enough. And also, it was something like, I am a bad person, I am a weak person, and therefore this has happened to me, and that's why I'm not able to get better. But I knew that was not the case, because I knew myself to be one of the strongest people. And as far as the whole thing of resilience is concerned, I was one of the most resilient people. So, what had really gone wrong? I looked at all the resources which were available, and thankfully, I live in those times and ages where, there's a lot of information on the internet. Knowledge is kind of democratized now. We can all have access to various resources, read up, decide for ourselves what is working, what is not. So then I decided that, okay, enough with the stigma. The stigma stops with me. I want to tell people that I have a mental disorder, and it's not a weakness of character, and I'm not ashamed of this. And that is when I started writing my book, The D Word, A Survivor's Guide to Depression. And after I had written the book got quite a good reception everywhere. Then I started talking more about my own struggles, more about mental health, and that's how I ventured into the area of mental health advocacy, where I have been speaking at a lot of different places, both about mental health, about major depressive disorder, and also my own experiences. So that has been possible because of social media, because of your mainstream media to some extent, and also because of my peers like Vijay, who have also been speaking out, and a lot of us are providing peer support in many different ways. And the peer support includes the literacy aspect, telling people about what it is like to have a mental disorder, what it is like to live with it, and what are these disorders. They are not just weakness of character. These are something that can happen to anyone. So, what have been my experiences in this journey? That is what I'm going to share with you. So the learnings from my experience, one of the first learnings was that mental health literacy is not dependent on your socioeconomic class, or the educational status. Because I came from a middle class family, I'm a civil servant, fairly well educated, post grad, but I had no clue. As I said, no one in my family, not even doctors, not even the various specialists of surgery, medicine, etc. No one had a clue about mental health literacy. Then there is no screening even in the formal health settings for potential distress, because as a new mother, I should have had this. I should have been screened for postpartum depression. I was not. So these are things that these are the gaps that exist as far as mental health literacy is concerned, because it is not a part of the protocol. At least it wasn't when I became a mother for the first time. There is stigma even in healthcare workers, and shockingly, even in mental health care workers. Even psychologists have asked me, why are you sad? Why do you have depression? And you write sad books, naturally you will be depressed. This is what someone said to me. So the stigma is very deeply rooted. Then there are extreme narratives in media and social media, and I have been at the receiving end of quite a bit of this, because you have on one hand you have this whole this stigmatizing model of what a depressed person is supposed to look like, or someone with a mental disorder is supposed to look like, and these stereotypes are further perpetuated by popular literature and cinema, that you're supposed to have matted hair, and you're supposed to be clothed in rags, and that again is very unfortunate, because there are people who do live like that, and that is not their choice either. Neither is it my choice, nor is it of the people who actually live like that. And then you have that on one hand. On the other hand, everyone is made a hero. Like I also read a lot of things that are said about me. I am also projected as some kind of hero who decided to talk about my lived experience of a mental disorder. That also is not true. I'm just an ordinary person who's trying to use my own sufferings, whatever I have been through, to help make a better place. Just doing my bit for society, and I'm no hero. And I still have my bad days. On certain days, I still feel very low, and I still end up wondering what is happening to me. And then I take a reality check. Okay, these are the depressive thoughts. I need to come out of this, because this will lead to a downward spiral. That's a different thing. I'm able to do that now. I wasn't able to do this when I had very severe depression. But these extreme narratives are there, and also these extreme narratives of psychiatry and anti-psychiatry. I have seen people push pills and just talk about depression as a simple problem in the brain chemistry. Then I also have seen people on the other hand who say that, okay, there's mental illness has nothing to do with the brain. And in fact, I was told very badly, and for saying that something changes in the brain when someone has a mental disorder. And I have seen people on the other end of the anti-psychiatry spectrum, who will go on to say that, who probably do not acknowledge that thought and behavior also have neurological correlates. Whereas the truth is somewhere there in between. This is what I have been always trying to say, that we have not even scratched at the surface. The human brain is extremely complex. And of course, the social and the psychological and the biological determinants of mental health as well as mental disorders. So these extreme narratives further do not give out a very clear picture of what exactly it means to have a mental disorder. And then again, I have seen that all the discussion that happens on the TV channels and on mainstream media is basically restricted to the participation of mental health professionals, whether they are psychiatrists or psychologists. And the whole idea of nothing about us without us gets completely missed out. Survivors, who are the biggest stakeholders, caregivers, you will rarely find them being called for any kind of discussion or any kind of dissemination of information, as you have called your conference, on in the space of mainstream media. So what again I would like to say is that, well, because people, there is stigma and there is silence, and the stigma which is there forces people who have mental disorders to stay silent. So much so that I have had a colleague who created an anonymous Amazon account to buy my book and read it, because of the fear of someone finding out that she's reading a book on depression, and it may have been very difficult for her to explain that. So that is the level of stigma that we still have around us. So what happens is that the stigma forces people to remain silent, and when people remain silent, when survivors and caregivers, they remain silent, so the stigma further perpetuates, and this is a kind of unbroken, unending cycle which goes on and on and on. And that is what we really need to break, is my opinion. So what happens? What are the fallouts of stigma? So the information in the public domain does not permeate or percolate. For example, as I said, I have written a book exactly for mental health literacy, except that when I wrote the book, I did not know there's a term for it, which thanks to this conference, I know that there's a term for what I have been doing. It's mental health literacy. But then uh, having written a book, and the example that I just shared of the colleague who had to create an anonymous account. So in that case, there is no point just writing a book if people are not going to read it, if there is so much of stigma. So information is there, but it does not percolate. It does not permeate down the layers of stigma that are built around this subject. People are afraid of reading about mental health for fear of mirroring symptoms, which is, if I read your book, is it that I'm going to discover I also have this thing? So I am scared of reading the book. This is some of the feedback that I have received from colleagues and friends. So people are still, that the stigma still maintains. Then mental disorders are seen as weakness. People are not willing to be seen as weak. And therefore, people don't want to read about it. People don't want to further explore this whole area. Rampant use of ableist language when discussing mental disorders. Again, on Twitter, I found a mental health professional saying that I don't take anti-anxiety because I don't want to use any crutches for living my life. Now, this is completely unacceptable because this is ableist language. People who have mental disorders have a disability. You may not be able to see it, but it exists. And using this kind of language really invalidates everything that someone with mental illness is going through. And I have already discussed this earlier, that extreme narratives, they dominate public discourse. So, of course, everything comes with a cost. And when there is inadequate mental health literacy, it has its own costs. So, let me just go through what are these. People remain outside the mental health care system, like I did. For 5 years, I was outside the mental health care system. Increase in disability leading to loss of quality of life? Definitely. If someone has a treatable condition, but if they are not able to access care at the right time, then the disability goes on increasing. Worse outcomes for untreated or late diagnosis. Economic and social cost of untreated late diagnosis of mental disorders. Strain on the formal mental health care system. Naturally, because if someone is diagnosed early, if they receive help early, they would probably have a better prognosis. They would help. They would become better earlier. But if they don't, then obviously the illness goes on increasing, and it comes at a much bigger cost on the formal mental health care system. Costs are the most for people without agency, for example, women, children, and elderly, because they literally do not have access to mental health care. And if their family stigmatizes, if the family is not aware of the fact that they need to access mental health care, they will not get it. So, this again is something that we need to keep in mind when we are talking about mental health literacy. And then the stigmatizing social environment further disempowers and disables. And this is something that I completely speak from my own experience, that the social environment, I have been so vocal, so outspoken about everything that I have gone through, but I still see all the snide remarks, the comments, the lot of things which, lot of negative feedback that I keep getting even now. So, what is the way forward? Now, the way I see it is, here I'm just sharing a few of my personal thoughts. One is the multi-sectoral all of society approach, because mental health literacy is mental health is everyone's business. It's not just a psychiatrist or a psychologist or even the survivors and their caregivers. It's a society-wide problem. It has to be seen from an all of society approach. Because, for example, like mental health now, separating it like from physical health. Now, the two are intertwined always. Mental health is always there. It's always a component and often of an individual's overall life. So, if someone has, let us say, suffered a heart attack and they are recovering from it, they may also have fragile mental health. So, that is why we really need to keep this in mind when we are talking about literacy. Include people with lived experience and caregivers. Nothing about us without us. Mental health literacy should also be taken care of in institutional settings, and especially healthcare settings. And on this context, in this context, I would also just like to say that because school mental health literacy was spoken about. So there, I would just like to say that it's not enough if just children. I mean, catch them young is definitely fine, but it's not enough if children are given literacy about mental health. If their parents are not mental health literate, then there is no point, because they do not have agency. If they have an issue, they will not get the help that they need. So those are things that we need to have in mind when we're talking about institutional settings, because, as I said, it's an all of society approach. You cannot segregate that, okay, children should be this, but if you don't address the parents and their lack of awareness, then it's not going to be all that useful. Then use of local languages audiovisual media and storytelling. Because in fact, storytelling is something that I have used in my own book as well, because the first chapter where I've tried to capture the various aspects of depressive disorders, I have done that through little stories of people. And again, this was, I think, raised by Preeti as well, that we do need to use local languages, because most of the information that is there is on platforms which are not Indian platforms, but from the West. And most of the literature and the material that you find on mental health is in English. So we really need to develop more resources in the local languages so that it reaches even down to the lowest levels of society, people who do not have English as one of the languages that they know. Then some kind of consensus, I believe, is needed on narratives. I feel that there is a need to bridge the gap between the extremes that I have already talked about. And of course, community participation, because we are all in it together. It cannot be that, okay, one person is affected and it doesn't affect. After all, we all live in society. We all live within a social and cultural context. And it's extremely important to take all of that have that in mind and take everyone along when we are trying to move forward in mental health, in the area of mental health. So that's all. That's these are just a few thoughts that I had, and
Thank you,
what's this?
Shubhrata, for that fierce conversation. And I think it's music to many of our ears in relation to your experiences and many of the key points that you have actually said. And I take my hats off to you for that. And I think I'm glad that you're actually with us. And also Vijay and many other people as well. And I think it begs the question, who is the expert here? And I think it's important that that question need to be answered in the broadest context here. Who is the real expert? And I think it is time that we should look at the Western psychiatric model with bit more sense, perhaps, and I think look at the ways in which need to be developed further. And I think it is still in its infancy, and it is not the be all and end all of everything. So I think it's important that we try and look at that. So anyway, let's. I think we have a few minutes. I've been granted 10 minutes to actually ask from. So we'll try and look at some of the quick key questions or comments that people may actually have. There are a few questions, and I think some of them Vijay has answered a few of those things. I think in terms of earlier ones, the community programs. Actually, there's something about community programs suggests that understanding the community first, and Indus seems to be important. And any suggestions on programs for collecting relating to MHL? Any comments from you, panel, about the community programs?
If I may add.
Yeah, please do.
Yeah, so I think there are enough and many community-based programs in India, and few of them are listed as our partners on the MHI website. But I can also tell that there are very few who are partners. There are enough who are doing great work outside, and I think it's just time and effort that needs to be taken to identify these community-based programs. Like programs like peer support work that Shubhrata and Vijay talked about are also community-based programs. So I think, and you won't find them on MHR website. So I would say there are many community-based programs. Yeah, sorry.
Yeah, that's fine. Thank you. Can I ask Dr. Rajib in relation to the systems thinking? How does the community programs and how where do we see that going from the policy perspective in systems thinking briefly?
I would link to the multisectoral approach or the relevance of the multisectoral approach that the last panelist made, and essentially she focused on how both community-based approaches as well as multisectoral engagement is crucial, and she represents the government also in other forums, I'm sure, and
Just sorry, I'm here purely in my personal capacity.
that's why I said in other forums.
Yeah.
So and we do have a lot to learn from an increasingly multisectoral engagement and building community as an actor in that multisectoral. Often multisectoral gets reduced to bringing the government departments in, which is not very inclusive multisectoral. It does include private sector. It does include community organizations as an actor or stakeholder. And I think recognizing that is extremely important. Thank you.
Okay. Right. We have another question in relation to necessary accommodations that should be given with children with special needs. And you can highlight the legislations and the process of how parents can claim these accommodations. In relation to, I presume this is actually in relation to the children, the kind of mental health and well-being of children with disabilities. Anybody wish to comment?
I just like to add that there is a government website that talks about the various disability schemes that are available. I'm just trying to see the link. It's called swavalamcard.gov.in. So that's one of the places that you could look at in terms of benefits available to people with disability.
Okay, thank you very much. Looking at case examples to understand systems thinking that was successful. Can we have? I think that's a big question in terms of can we have case examples to understand systems thinking? Yes, I think we can contact Dr. Rajib in relation to that about examples of how we move forward in relation to that. Shubhrata, can you share your experience of how your family members supported you in your journey of recovery? Since that's an important point.
Definitely. I have written about this in detail and I keep speaking about it. Like, my husband was on board from day one. He's been the most supportive person and he's been a rock in my life. And I honestly wouldn't have been here to speak if it wasn't for him, because he kept me alive during those really, really dark days when I couldn't eat anything and when I often was. I mean, trigger warning for people who are watching this, but there were days I didn't want to live, and he kept me alive through all of it. So there's no issue with that, and my husband and the kids were the reason why I kind of just pulled back, and everything that I do, and even now when whenever I am assailed by any kind of thought which is trying to drag me back to those depressive days, so that's there. But then, other than that, the rest of my family, whether it was my parents, my sisters, my in-laws, it took a little time for everyone to again. There was no mental health literacy, so it took time for people to understand what was happening to me, and it took some time for them to come on board and support me. And of course, they all supported me at different points of time. My parents, my in-laws, and in my children also, so that has been my experience, but mostly it has been my spouse. He's been my primary caregiver. He has supported me through all of this, and I've seen marriages break down, etc., because of this. So I really don't know what to say except that maybe I was just fortunate. Shouldn't have to be, but then that's how it is.
Thank you very much. Thank you for that. I think one final question here. I think we'll go to Dr. Rama Kumar and Mr. Vijay Nallawala with this. And how can one replace an avoidance orientation with an approach orientation to problems? Very much in tune with the resilience model kind of things. Over to you, Dr. Roma.
Thank you, Professor. Well, we always have, these are conflictual situations, when there's a conflict, you have either you have approach, or it's approach avoidance, or it's completely avoidance. Now, I think what needs to be done is you need to evaluate what are the things that are making you feel that you need to approach it, and what are the areas that you feel you need to avoid that. What are your triggers? I think take a paper, pencil, and put it down there. See it in black and white, that what is it that is going to be fulfilled if you approach the situation, and what is it that is going to be fulfilled or is going against you if you avoid this situation. And you will get your answers right there and then. Yes, we do get attracted to doing both the things together, but that's not possible. We need to take a decision for ourselves, and that's what is going to help us bounce back, and also learn to rebalance things in our lives, and also prioritize in our lives. When we have a situation, for example, after grade 12, we have to decide which career we need to get into. So we always tell children that have a plan A, plan B, plan C in place. You can't just have one plan. So that's what is, going to help you understand approach and avoidance. I hope I was able to answer that question.
Thank you very much. Vijay, which
Yeah, sure. I think we have had a lot of experience in this regard because denial is the key component in the journey of people living with mental illness. All right. So I remember just a couple of months ago, I was referred to a person from Delhi by a professional, okay, by his own psychologist. That I think, Vijay, you will be able to break the barrier here. That guy was off medication for 2-3 months and in dire straits, bedridden, and a pep talk with him about sharing just about how I came out of my strife, the discipline I adopted. And, sometimes it just needs that kind of a push for that person to, that nudge. And it is not about trying to bulldoze that person into making that decision, but it is just that bit of reassurance that the person needs at that point of time, and from a person who understands his problem and he can relate to. So maybe a professional's words don't resonate as strongly in that context as a person with lived experience. And now that guy is absolutely turned around in this span of 2 months, and he's still in touch with me. And this we witness across our peer support community. Some are just silent spectators. They observe behavior of the community, and it inspires, adherence to the discipline model. And one more insight I would like to share. Sometimes denial happens on the part of family carers also. All right, it is not only on the behalf of the person with lived experience. So our community encompasses not only the PMIs but also families, and we have experienced turnaround stories of how families realize that this person is not lazy, he's not being adamant, it is just the symptoms of the illness which is making him do this or making her do that, right? So of course peer communities and individual experiences also can be a game changer.
okay. Thank you very much. On that note, I think I must actually. It's been a long time. I think we were slightly delayed, but I think this is enriching conversation. I'm happy to sit here for the next 4 or 5 hours if you wish to. But I think carry on this conversation because it's so enriching, so enlightening, and I think it's making a lot of sense in terms of knowledge and how knowledge should be used proactively in terms of how systems need to be feeding into that process, and our professionals need to be more understanding about the users and carers' needs and how things need to move on. And I think the status quo is not the right thing, and also eradicating the stigma and fearless talk and conversations in terms of thinking about new directions and new ways and new approaches and diverse approaches of how we move forward. So I'm extremely grateful to you all for taking the time to come here and talk about the experiences and also the kind of ways things need to be improved. Thank you very much indeed. Before we go, just to and I think concluding session, this is and I need to say a few words, and also Ash, I need to say a few words as well about it. So it's great to have you there, and I think all these things actually came about 3 years of our work and conversation with many of you here outside this room, and also in terms of a lot of people told me when the pandemic came on in February last year, we just had come back from India at that time, and still longing to come to India, and I think it is sort of so that you can't do anything. But I said, the true talk of resilience, and now I understand from Dr. Roma's conversations about resilience, and that people said to me that no, you can't do anything. I said we can. I didn't know the answer to it, but answers came later on. And I think we sort of dived into the kind of digital media. We still engage with people with films and storytelling and a lot of other things are possible. So without even the face-to-face conversation, we could still reach some of the rural communities, urban communities, etc. So, but sometimes we don't know the answers to it. But I think answers might come, and I think that is purely from my personal experience. And I think it's important that we go through that process. So thank you very much indeed. And Asha, concluding word from you.
It's already 8:30. I don't have any words, but thank you so much for all the honest, straight from the heart conversations. And in fact, today when I started with my presentations, I was looking at the mental health landscape in India, and I was looking at where are the users groups. So now I can find the users' voices in this, and really thankful to meet Mr. Vijay and Shubhrata ji. Really, the voices have to go a long way to fight stigma, and your voices are very significant. And definitely, we will connect together and work to create a huge impact. Thank you so much, everyone.
Sure.
Yeah.
Thank you, everybody. Thank you.
Thank you, and I will be knocking on your door soon. Thank you very much, and good evening. And we'll see you. See the participants tomorrow. We have an exciting session tomorrow as well. Thank you very much indeed.
Thank you.
Good night. Good night, everyone.
Good night,
Thank you.
everyone.
Thank you. Bye-bye. Yeah.
We hope that today's session was informative and you do have a few key takeaways. Thank you for coming today.